Hello and welcome to Healthy Liver, Healthy Life, a podcast series where we talk to leading medical experts about liver health and advancements in treatment. In today's episode, we are joined by Dr. Deepak Koppaka, who is a senior consultant and medical oncologist from Hyderabad, to discuss hepatocellular carcinoma, which is the most common type of liver cancer. So, my first question to you is, how has the global incidence of HCC, which is liver cancer, changed in the recent years?
So globally, the incidence of HCC or liver cancer has continued to increase. Over the last 1 decade, what has happened is the incidence of liver cancers have increased, and previously liver cancer increase was attributable to viral etiology. With the advent of hepatitis B vaccine and better antiviral therapies, the incidence of viral related HCCs have come down. On the other hand, the new epidemic that's happening in HCC is in relation to fatty liver. So metabolic disorders or obesity and hypertension, diabetes, patients with these disorders eventually have fatty liver. And this is now becoming an epidemic. Now the global increase in HCC incidence is attributable to the NASH related cirrhosis related HCCs. On the context of global trend, what we see is the Western world, US, England, the European nations, we see there is an increased incidence and also prevalence of these type of HCCs. On the other hand, countries like ones belonging to Africa or the Eastern Asian countries like China, Taiwan, here we see a lot of hepatitis related HCCs. Unfortunately, the NASH related HCCs incidence is increasing. In countries with less access to medical treatment like the African countries, an increased incidence of HCCs is of late been seen. Coming to India, we see HCCs in the northeastern states and at higher numbers than what we see down south. Here again, it is attributable to the viral etiologies.
So, can you tell us again what are the major factors, risk factors that are actually causing HCC?
So, like I was telling you, now if we have to categorize the factors that have led to HCCs, we all know HCC is a disease or liver cancer is a disease we all attribute to alcohol consumption. So, time and again, heavy alcohol consumptions, people who are used to heavy alcohol consumptions, there is an increased risk of cirrhosis leading to HCCs. The other etiology is hepatitis infection. Again, we know liver infections, which if not treated adequately or if there is chronic liver infection, we see there is an increased incidence of liver damage because of the viral infection leading to cirrhosis followed by viral etiology related HCCs. Of late, the new trend, the new factor that is increasing the risk of HCCs is fatty liver, secondary to metabolic disorders like hypertension, diabetes and obesity. In these diseases, because of excess fat deposition in the liver, there is a liver cell injury leading to cirrhosis followed by again liver cancer. There are other factors like aflatoxins and industrial pollutants, smoking, which also increase the risk of HCCs. But the three main etiologies boil down to fatty liver, viral etiologies, and alcohol consumption.
Okay. So you told what are the leading factors actually, but which are the group of people who are more likely to develop HCC?
So population of patients who have hepatitis infection, chronic hepatitis B, hepatitis C infection leading to cirrhosis, these are the group of patients where the incidence of HCC tremendously increases. Again, alcoholic cirrhosis, patients who consume alcohol despite having cirrhosis, and there is further liver worsening because of cirrhosis, these bad livers tend to develop HCCs. And then we have the fatty liver or NASH associated HCCs. Age groups, the NASH associated and the alcoholic HCCs are predominantly in the elderly age group beyond 50 years and above. In the younger age group, patients with hepatitis B, chronic hepatitis B infection, even in the younger population, we see hepatocellular carcinomas.
Why do you think it's so important to detect HCC in the early stage?
Yeah, so HCCs, if we detect them in an early stage, we can detect cirrhosis also in such patients. All we can do is a liver transplant, remove the bad soil, that is remove the cirrhotic liver along with the cancer. In such situation, the cure rates are more than 90%. On the other hand, we have HCCs with stage 4 or where HCCs are spread to other organs. In such patients, what happens is the survival drops drastically to less than 15%. So there's a stark difference. Somewhere the survival is on 90%, whereas in the advanced stage, it falls drastically to less than 15%.
Okay, so what are the usual recommended screening methods used for early detection of HCC?
So in patients where there are higher risk, like patients with hepatitis B, hepatitis C, active hepatitis B and hepatitis C patient, we recommend an ultrasound of the liver every 6 months. On this, what we see is whether there are regenerative nodules, whether there are cancer nodules or lesions developing in a liver that is cirrhotic. So this is the current recommendation. Certain situations we also use tumor markers like alpha fetoprotein and PIVCA to help us come to a diagnosis. But for screening, strict recommendation limits itself to only ultrasound of the abdomen with clean focus on the liver.
So are these screening methods and diagnostic tools easily available to the people who are actually at high risk?
So at the risk population, at least in patients with hepatitis B and C, we know ultrasound is available routinely across most diagnostics. Even in the rural areas, we see ultrasound availability is even effectively available than the more expensive scans like CT scans or an MRI. That being said, certain parts of India coming to northeast and in remotest of the areas, even access to an ultrasound is difficult. But in such patients, at least an annual liver screening using an ultrasound is recommended.
So what do tumor biomarkers, what are their roles in the HCC testing?
So a previous decade back, most of HCC diagnosis, again the problem with HCC diagnosis is the liver as such is bad. In these patients, because of cirrhosis, the liver is already bad. What happens in such situation is because the liver is bad, when we do a biopsy, sometimes that small insult to the liver itself can cause the liver to fail. This is called decompensated cirrhosis. So to avoid that, we use routine CT scans or an MRI to come to a diagnosis. A decade back, we didn't have adequate tools or standardization to say which imaging findings are pathognomonic or what define HCCs. In that situation, we used to use markers like alpha fetoprotein. Recently, we are using a newer marker called PIVCA. So these two markers have the biomarkers that were helpful in coming to a diagnosis of HCC. But of late, even the current American guidelines and even the Indian guidelines recommend a good CT scan or an MRI are good enough to come to a diagnosis of HCC. And we don't have to rely on AFP or PIVCA. Now that being said, it is also important for us to understand that in such situations, we do AFP, we do PIVCA for us to monitor the disease. So we don't have to do a CT scan on a regular intervals to see whether the disease is responding or the disease is recurring. So we use these markers to follow up the patient and assess their response to treatment.
So are there any new or promising biomarkers available for the HCC detection?
So currently, alpha fetoprotein, PIVCA are used along with, in conjunction with CT scan or an MRI. They are not in alone helping us to come to a diagnosis of HCC. That being said, we have newer techniques like ctDNA, mRNAs and liquid biopsies. These would help us to identify early recurrences or resistance to treatment. Again, we are not there yet to use them into routine practice. They are still in the research. We are doing clinical trials to see whether we can validate this into routine practice. But we cannot just rely on these markers to come to a diagnosis of HCC and treat patients based on that.
So what are the limitations actually of these biomarkers in HCC screening?
So the current biomarkers that are being used like liquid biopsies, ctDNAs, mRNAs, again have inherently low sensitivity to detect cancer early. That also will see that we effectively have to do a biopsy in certain cases where it is possible or rely back on the routine CT scan or an MRI to come to a diagnosis. We just can't rely on these biomarkers to come to a diagnosis. Again, sometimes diseases like testicular tumor, ovarian tumors also produce AFP. So we can't just simply rely on a tumor marker called AFP and say because the AFP is high, it is liver cancer. It could be other cancers or some benign disease also, AFP can go up. So these markers have a lot of sensitivity and specificity issues. So we can't just rely on them. We always have to take them in consideration with the imaging finding.
So how do doctors actually stage HCC, that's liver cancer, and why is it important?
So unlike any other cancer in the body, liver cancers or HCCs, there are two issues that a patient has to handle. One, the bad liver or cirrhosis, that if left untreated, that itself can cause life-threatening complications. On the other hand, they have a cancer that is spreading in the rest of the body. So using this, we traditionally use the BCLC staging, that is Barcelona classification for liver cancers. That staging is used. Here, if the tumor is limited and it is small in the liver and there is only one lesion, we call it as a BCLCA or first stage cancer. If it is multiple and involving both lobes of the liver, it is called BCLCB. If it has spread outside the liver, it is called BCLCC. And if the liver itself is decompensated and the patient is not fit for any other treatment, it is called BCLCD. So this is the traditional classification that is being used, considering both the cancer part and also the liver component.
Okay, so what imaging techniques, like it can be CT scan or MRIs, are useful to actually figure out the stage of HCC?
So imaging modalities are a triphasic CT scan with a liver protocol. This is the standard for imaging that we do, first to see the extent of the disease in the liver and also the characteristics of the nodule, whether it's a regenerative nodule or a cancer nodule in the liver. After this, we try to use a CT thorax to understand if the disease has spread to any other organ. And if there is a doubt, we might have to use an advanced imaging modality called an FDG PET CT scan. In patients where the imaging findings are ambiguous and we are not able to effectively come to a diagnosis, we do second imaging modalities like a contrast enhanced MRI, and that can help us identify liver lesions better in certain situations. Rarely we use an ultrasound to identify the liver vasculature, but routine practice we use CT scan and an MRI.
Have there been any recent improvements in how doctors stage or predict outcomes in HCC?
So in HCCs, before we initiate any treatment, we try to identify the risk of the disease coming back and the risk of the disease causing death. So the traditional and the most effective thing that we continue to use is the BCLC staging. Along with that, to understand the liver function, we use the Child-Pugh score or the ALBI scoring system. There are multiple nomograms that are being developed to identify the risk of a patient responding to a particular treatment and the risk of the disease coming back, which have not yet come into the routine practice and have not yet been standardized. So in the near future, we are expecting more such nomograms to help us identify the risk of recurrence and the exact staging and outcomes of a patient.
Tell about the main treatment about HCC. How can it be treated?
So the traditional treatment again is based on the stage of the lesion. So if it's a BCLCA and if the lesion is resectable, we resect it. And during this process of resection, if we think that the liver can undergo decompensation, the cirrhosis is very bad, we do a total liver replacement with a liver transplant. This is called a live donor transplant or a cadaver transplant. We remove the liver and place a new liver in these patients. And with this, the cure rates are very high. In certain situations where liver transplant is not feasible, the liver is healthy, all we have is a liver lesion and this patient is not willing for surgery, we have advanced treatments like ablative treatments called radiofrequency ablation, microwave ablation. Today we have advanced radiation techniques called SBRT to tackle such lesions. In situations where the lesions have gone into multiple lobes and resection and transplant are not possible, we do a very advanced treatment called transarterial chemoembolization or radioembolization. Liver has this peculiarity of getting two blood supplies. Like any other organ, you have an arterial supply called an hepatic artery, but again there is another venous system that drains into the liver called the portal vein. The portal vein is a system where all the nutrition from the intestine is collected and that is transported to the liver. So tumors get their blood supply from the hepatic artery. What we do is we occlude the hepatic artery by giving a drug called embolization, and this embolization material is filled with chemotherapy. So it goes and it clogs the blood vessel and there is chemotherapy that seeps on a frequent basis into the tumor and killing the tumor. So this is called transarterial chemoembolization. Some places we remove the chemo material into this embolus material and fill it with radioactive material, and that radioactive material seeps in regularly and kills the tumor. So using these techniques, we are effectively able to control stage 2 or BCLCB tumors. Of late, in stage 2 BCLCB patients post-TACE or in patients with advanced disease, we have a very new treatment called immunotherapy. Here we see that body's immune system is enhanced and the body's immune system is then going and fighting against the cancer and eliminating it. In certain patients, we also use targeted therapy which specifically targets the tumor microvasculature at a microscopic level and occludes them and kills the tumor better. So there are multiple treatments and all these treatments have changed the way we treat this disease. At one point of time, a decade back, HCC, the treatment options were very limited. Today, we have more than 5 very advanced treatments just in the first line, improving the outcomes of these patients.
Finally, my question is, what are the biggest challenges that both doctors and patients go through while handling and managing the HCC, that is liver cancer?
So challenges, if I have to say, one is awareness about HCC. So any patient with hepatitis B, hepatitis C infection should undergo regular screening. It starts there because there, if we are able to identify the lesion early, we are able to cure significant proportion of patients. Second, using active hepatitis B and hepatitis C treatments. Third is about access to healthcare. Now, off late, immunotherapy pricing has come down. There are multiple pharmaceutical industry companies that are cutting down the price of immunotherapy with better patient assistance program. The access to these drugs have improved significantly. Now we have the generic immunotherapy drugs which have further reduced the cost of these treatments. So overall, the challenges are there, but there are ample opportunities that are opening up in the management of HCCs, and the outcomes and the options of treatment for these patients have improved dramatically.
Thank you, Dr. Deepak Koppaka, for sharing your thoughtful and valuable insights on hepatocellular carcinoma. That's all for today's episode for Healthy Liver and Healthy Life. Stay tuned for more such conversation on liver health with more leading medical experts.